Okay, great. So pleasant good morning, everyone. Today we'll be looking at the cardiovascular system. Wanting to ask a rhetorical question, is the cardiovascular system important? Oh yeah, very important. And when we think of the cardiovascular system, what organ is the man or the woman, the important one in terms of the cardiovascular system? What organ is the most important one associated with it? The heart. Thank you very much. Yeah, the heart. All right. And you know, very interestingly, when we think about the heart, oftentimes we hear many songs associated with heart, right? Don't go breaking my heart, you know, oh, you take my heart and you run away with it. All kind of songs related to the heart. And oftentimes I wonder, well, why it is that, you know, all of these songs were made concerning the heart. At one time, the heart was considered to be the center of emotion, particularly those associated with love and feelings, deep feelings of emotion. So that is why, you know, from a traditional perspective, which is why when you look at Cupid and the whole notion of Valentine's, you know, it's always related to the heart, because it was felt that the heart was the seat of emotion. It wasn't until later on in the 19th century that they recognize or begin to appreciate the importance of the brain as the seat of emotion and reasoning. And therefore that thought moved, but, you know, still all of those traditional songs remained. And probably they thought, you know, if you sang a song like Don't Go Breaking My Cerebellum, it wouldn't sound as good as Don't Go Breaking My Heart. So they just left it as is. Cardiovascular system, let's go. So the cardiovascular system, as we just mentioned, the heart is among the most important components of the cardiovascular system. When we think of the circulation, we have circulation between the entire body, what is known as the systemic circulation, and then you have the pulmonary circulation, that which goes between the heart and the lungs. Again, whenever you hear the term pulmonary, pulmonary refers to the lungs. So anytime you hear something related to pulmonary, you immediately start to think about lungs. And what word or phrase or part of a word is usually associated with the heart? 6 letters. And it has a singer named something B.
Cardio.
Cardio, right, not to be right, not cardio, right? So cardio indeed refers to the heart. So pulmonary circulation, when we look at the heart, the systemic circulation brings the blood. Are you all seeing the hand that is moving? You're seeing it? Okay, great. So when we're thinking of the systemic circulation, again, systemic refers to the blood returning from the body itself. Blood enters the right atrium. So the atria, plural of atrium, the atria, we have a right and left atrium, and blood always enters. So get it in mind, whenever you hear about entrance, getting into the heart, the first thing that should come to mind is the atrium. So the blood, be it from the systemic circulation, it comes in the right atrium. And if it is coming from the pulmonary circulation, i.e. the lungs, it enters via the left atrium. From the atrium, it goes down to the ventricle. So you can think of the atrium and the ventricle as 2 floors: atrium, top floor, ventricle, bottom floor. So from the top, according to gravity, how things move, up or down, according to gravity. If you throw something up, what will happen? It falls down. Right, exactly. So the blood, after entering to the atrium, it will go down to the ventricle. Now, this blood that is coming from around the body, as it relates to oxygen content, would you say it's high in oxygen or low in oxygen? It's now coming from all over the body, right? Is it low in oxygen or high in oxygen?
It's low in oxygen.
It is low in oxygen. And again, what is that oxygen? Why do we need oxygen for? We looked at this in SNF1. Why do we need oxygen really? For 3 words: break down. We use oxygen to break down food. Yeah, food, right? There is the equation: carbohydrates plus oxygen gives you carbon dioxide, water, and energy. right? C6H12O6 plus 6O2 giving you 6CO2 plus 6H2O plus energy. You all would have seen that equation many times, but the basis of it is carbohydrate or a food source plus oxygen gives you, as a waste product, carbon dioxide, which we breathe out, CO2, water, which is also present in the air we breathe out, and most critically, though, is used to produce energy. Energy in the form of 3 letters. What are those 3 letters that associated with energy in the body? It's a single currency, like the links card of the body for energy. What is that? What are those 3 letters? Not an ATM, but ATP, right? Not ATM. Huh? So don't go write in ATM if you have an exam. It's ATP. But which is a nice way to correlate, you know, in terms of a universal, it's a currency. So just like an ATM card, ATP could be used all over the body itself. Let's get back to the heart. So this oxygen poor blood, right, after it's come into the heart from the systemic circulation, it goes into the right atrium down to the right ventricle. So it needs to get oxygen. So what happens? The pulmonary arteries, hello, carries them to the lungs, where it is now oxygenated and is returned to the pulmonary veins. Now, we'll be looking at this next class day, but in general, arteries carry oxygenated blood and veins, for the most part, carry deoxygenated blood. So why is it that they name these the pulmonary arteries and this one the pulmonary vein? Because this one is rich in oxygen. Hello, it's coming directly from the lungs, so it's full up of oxygen. Why didn't they call this the pulmonary artery then? And this one the pulmonary. Why did they choose these 2 names? Anybody? It has to do with another property associated with arteries and veins. Anybody knows why they call it then this one the pulmonary artery and this one the pulmonary vein?
Because the ventricle, well, it pushing more force into the lungs rather than the lungs don't push the amount of force that the
It
heart.
has to do with force, correct? So in other words, what you're aiming at is it has to do with a property associated with arteries and veins. You're right. And I'm glad it's related to the direction. In general, when we think about arteries and veins, which ones carry blood away from the heart? Arteries or vein?
The arteries.
And what brings blood to the heart?
Veins.
Yeah, and they use that criteria when they were actually naming it, because not technically, in essence, this is part of the heart. The blood is leaving the heart. It's totally leaving the heart and going to the lungs. So that's why they call it the pulmonary arteries. And here, it is returning blood to the heart. So they named this the pulmonary vein. So in other words, when they were using the nomenclature or naming the blood vessels, they chose veins because this one is returning the blood to the heart, and pulmonary artery, in this case, this one is taking the blood away from the heart. All right, remember that. It's almost certain you'll get a question on that, you know, in your multiple choice somewhere along the line. That's a favorite question to ask. All right, so the rationale behind it is arteries take blood away from the heart, veins bring it towards the heart. So it's returned to the left atrium, it goes to the left ventricle, then it enters the systemic circulation, the working body cells. All right. So it's nice to see this overview, right, in terms of the circulation of the blood. And now let's look at its location. Where is this heart located? It is located in an area known as the mediastinum. The mediastinum is a specific area between the lungs and inferior to the clavicle and your sternum, or below the level of the sternum and clavicle. So this area here is the mediastinum, and this is where the heart lies. A very nice way to remember when you're looking in terms of the heart and wanting to know which side is the right and the left. The apex of the heart always points to what direction? The left. All right, so very importantly, if ever you're confused, because it could get confusing, especially in the environment of an examination, you know, you're thinking, well, which side is the left side? Which one is the right side? Hello, look for the apex. The pointy part of the heart, it always points to the left. So therefore you'll know over here is the left side, over here is the right side. The heart itself, it has a covering known as the pericardium. Peri, if you remember from your mathematics, they peri. Could you think of a word in maths that uses or employs that word peri? Related to, let's say, a rectangle or a square, there's a particular measure that uses the word peri. The perimeter, yeah, because in essence, peri means peri means around, and meter means measurement. Actually, METR or METRE, French derivation of the word. So perimeter actually just means, literally, it means distance around. Right? So when we're looking here, the pericardium, this is a fluid-filled sac. Cardi, of course, relating to the heart. Peri means around, so it's around the heart and it's a sac, right? That in case, so all around the heart is it's like if you take your fist and you push it into a balloon filled with water. So you have a balloon filled with water that is knotted, and then you push your fist into it. What will happen? The balloon will just surround your entire hand or fist. In this case, the fist will represent your heart, and the balloon, the water-filled balloon, will represent the pericardium. So very important there in terms of appreciating that. And if I were to ask you why it is that you have a pericardium around the heart, one main reason to prevent what? Give me one word. It begins with F.
Friction.
Thank you very much. Yeah, friction. Because friction, you wouldn't want friction to, what would happen if, let's look at it this way. I think we spoke about this last day. Somebody asked this question, right? What would happen if you didn't have a pericardium? Well, the heart would begin to rub on the different organs. And as we mentioned, before it gets to the organs, it will start to hit the blood supplies. So what you'll have is hemorrhaging occurring. So to prevent that, you have this fluid-filled sac around the heart, the pericardium. And for those of us of the Christian denomination, you do know around Easter time, when you're looking at the Passion of the Christ, it is said, in all of the three Gospels, Coptic Gospels, that how when Jesus was on the cross, one of the soldiers came and pierced his side with a lance, and what flowed out? Immediately what flowed out was blood and water. Right? And from an anatomical perspective, now, a physiological perspective, what it is strongly believed in terms of the piercing with the lance is that the lance went through the pericardium and then the heart. So in terms of that clear fluid that they see, and that was recorded as water, right? Initially, that would be the piercing of the pericardium. And then, of course, when the heart was pierced, then you saw blood. So when you're thinking of that, outflowed blood and water, those who study physiologists would tell you that is related to the piercing of the pericardium and the heart itself in terms of water flowing out. Clear fluid that is in the pericardium, and then blood relating, of course, to the blood that is present in the vessels themselves. Okay, so the heart, here it is showing the location. Again, the apex pointing to the right. Here we have the diaphragm. Diaphragm, very important muscle associated with breathing. All right, and this notice location here. And when we look in a little more detail of the heart itself, we see the muscles and the fibrous pericardium and the serous pericardium. And of course, you have pericardial fluid that actually is between these two layers. All right, we look so far, we look at the heart as it relates to circulation in the heart, and we'll revisit it in a little more detail shortly. We look at the arrangement in the mediastinum. We see how the apex points a little bit to the left. It points to the left. So anatomically, you could be able to pick it out should you be shown a diagram. Now let's talk a little bit about the cardiac muscle. Cardiac muscle is unique. If you remember from SNF1, we have three. What are the different types of muscles we have? I forgot. Somebody remind me. So we have cardiac muscle, we have smooth muscle, and what other type of muscle we have?
Skeletal.
Thank you. Skeletal or skeletal muscle, right? Skeletal, smooth, and then we have cardiac muscles. They are all unique. Cardiac in particular is unique because of the period of muscle contraction. If we are to look at skeletal muscle here, it takes, in terms of the time it takes to contract, it's a very short period of time. However, with cardiac muscle action potential, it takes a longer time for the muscle to contract. So that is the one thing to appreciate with cardiac muscle. It takes a little longer to contract when compared to skeletal muscle. So why is that? So we have this contraction of the heart, and the reason why it takes a little longer to contract, because it has to pump the blood out of the ventricles and the atria, right, to circulate the blood through the body. Now, as we speak about circulating the blood flow through the body, where exactly or how does the blood flow through the heart in terms of getting throughout the body? Let's have a look. Blood, and this diagram, you'll be well placed to learn how the blood flows through it, and not only that, but the specific areas it flows through. So one question might come, just giving you this with all of these things blank, and let's say you mix and match or to drag. Now, we wouldn't use drag and drop because it doesn't work well when persons use phone. But let's say you have to match, you're given a list and you have to match up, which one goes where. So you'll have like numbers here, 1, 2, 3, 4, 5, and you have to match it. Where does it go? Let's have a look. So blood is returned from the systemic circulation, that is from throughout the entire body, via the superior and inferior vena cava. VC, superior vena cava, inferior. Why are they called superior, and why is this one called superior and this one called inferior? Anybody wants to hazard a guess? This one is superior and this one is inferior. Why?
So is it because of the position?
The position. Put a little gravy on that rice. The rice looking white. Put some gravy and put a piece of zabuka on the side of it. You're correct. But put a little gravy and zabuka.
So
Go ahead.
So one coming from the top of the body and the other one from the bottom half of the body?
Yeah, correct. Now, nothing was wrong with the first answer. If you were to put that in a response, you'd get the marks for it. I was just asking for a little gravy with a piece of zabuka. So the superior, because this blood is returned from areas above the level of the heart, right? So everything above the level of the heart is returned via the superior. Everything below the level of the heart is returned via the inferior. Could you give me some structures which are above the level of the heart, organs or otherwise? What is above the level of the heart? Give me some structures. Let me hear you.
The brain?
The brain. What else? Good.
The eye.
The eyes. Yes, yes. So anything associated with the head or the upper torso, right? Very good. What about below the level of the heart? What do we have below the level of the heart? Where that blood will be returning from?
The lung?
The lungs, yes. Well, the lower part of the lung, yes. Anything else? What's below the level of your heart? What structure? It could be an organ or
Kidney?
your kidney,
The liver.
your liver, well, the lower part of your liver, because the lower goes right across. Your spleen, yes, yes, the spleen is below the level of the midline. That's good, right? What about parts of your body? Two things walk on.
Your legs?
Your legs. Yeah. So blood is returned from the legs, from your big toe and so on, is returned via the inferior vena cava. So let's see how it flows. So if it comes into the heart, where does it go first? Does it go to the atria or the ventricle? When it's now entering the heart?
To the right atrium.
Atria, correct. It always goes in the atrium and it always comes in on the right side. All right. Let me see. It always comes in on the right side. I'm thinking if there's an exception to that. I'm sure there's some kind of condition where you have an issue with that, but it have to be corrected surgically. But normally, it comes in on the right side. Very true. Now, let me ask you this. Now, the heart itself is usually located in the mediastinum and to the left of the midline of the body. Is it possible for your heart to be on the right side? Of your sternum, located to the right. Is that possible? And is that consistent with life? And the answer is yes, it is. Amazing as it might sound, it's called a condition called dextrocardia. in which the heart is on the right side. Now, this is not on the syllabus, so you don't have to know it, but just telling you, you know, as a professional, would you ever see it? I've never seen it. It's difficult to see. So you might even see it throughout your professional career, but it does occur periodically that somebody has their heart on the right side, and it is consistent with life. So, you know, if next thing you're sounding somebody and they're there talking to you and so on, but you put the stethoscope on the left and you're not hearing anything. Right? So before you think they're a zombie or a zombie, you know, always put it to the right. Now, if you put it on the left and then you put it on the right and you don't hear anything, what do you do next?
So run.
Run, of course. You run far and run fast, right? Don't ask any questions, right? You know, some people will be like, excuse me, I'm not hearing. No. You put it on the left, put it on the right, not hearing anything, just keep running. And if you're in San Fernando until you reach Library Corner, go and sit down in KFC and catch yourself, and while you're there, you order something, okay? Let's get back to the heart. Superior, inferior goes to the right atria. From the right atrium, it then goes to the right ventricle. From the right ventricle, it passes through the pulmonary valve and it has to be oxygenated. So what does it do? It enters the pulmonary, on this side, the pulmonary vein or artery in terms of carrying blood to the heart.
Artery.
To the lung, sorry, right? Is it the pulmonary artery or vein that carries blood to the lungs?
So the artery, the vein.
Right, so this is the only exception. In other words, whenever you, so this one is at, what is it called here? If you were to look, the pulmonary trunk, and it's carrying the blood. Now, in terms of the pulmonary artery carrying the blood to the lungs, here we notice that it splits in two. Why does it split in two? Hello, because of what reason? Because we have two, what? That the pulmonary artery splits in two. Somebody said it just now, I believe. Lucille, was it you?
Too long.
Lungs. Yeah, I heard something very faint. Yeah, I think it was Lucille. Very good. Right? Because we have two lungs. So therefore it splits. And there's a nice word in biology, in terms of anatomy. A nice way of saying split is a word that begins with B and is bifurcate. You'll probably hear it. Bifurcates. So what you'd say is the pulmonary artery bifurcates in order to go to the left and right lung itself. Similarly, another structure that bifurcates is your trachea. The trachea bifurcates into the left and right bronchi in terms of going into the lung itself. But we'll speak more to that when we're looking at respiration. So here it splits. So each one going to the left and right lung via the pulmonary artery. So now it's returned, oxygen-rich blood returned via the left pulmonary vein, and it enters the left atrium.
Left atrium.
From the atrium, where does it go?
Left ventricle.
Ventricle, out through the, and no,
Aorta.
the aorta, major artery of the heart itself, the aorta.
Yeah.
Right, so that's the major artery of the heart, aorta. Now, you know, here this area here, it looks like a curve or an arch. And what is it called? Anybody? It looks like an arch, so they call it. Some things are not difficult in life. If it looks like an arch, what do you think they call it? The aortic what?
Aortic.
Huh?
No. Aortic valve.
This part here, it looks like an arch. Thank you. They call it the aortic arch. That's the name for it. This curve coming out from the aorta. And just a little FYI, if ever you hear somebody has a split or a rupture of the aortic arch, well, it's time to get your papers in order, right? If you have a rupture here, is a very big problem. Usually, even if they try to fix it via suturing and so on, it keeps bursting. So there's one area you really don't want to get any issues arise in the aortic arch. And why is that? Because when the heart contracts, it is coming under the highest pressure. It's coming out here under the highest possible pressure, and it hits this curve. Remember, it has a curve, and that's why you don't want to get any ruptures here, because usually if you do, they keep reopening. And it usually signals ... your time coming very close to talk to the ancestors. All right, let's just follow the blood flow again. blood is coming from the systemic circulation via the superior and inferior vena cava, enters the right atrium, goes to the right ventricle, then leaves the heart via the right and left pulmonary arteries. It is oxygenated and it returns via the, well, in this case, is the left pulmonary vein, but also not shown here. You have the right pulmonary vein empties into here as well. So both the left and right pulmonary veins coming respectively from the left and right lung and enter and deposit blood into the left atrium. From here, the blood goes from the left atrium down to the left ventricle and then leaves via the aorta to go back into the systemic circulation. All right, so yes, go ahead.
Hi. So the lungs, is the lungs, because I want to make sure on the right track. Do we call that the lungs there, the alveolar capillaries?
The alveolar capillaries? No.
Yeah.
No, capillaries, we look at structures. Capillaries are the connecting point between arterioles and venules, and they are really small. Really small. When we talk about really small, we're talking millimeters in diameter and millimeters and smaller in diameter. Right, so they're really, really small. Sometimes a person who are, as they say, light-skinned, like when you see, let's say they have a cold, sometimes you'll see some capillaries popping out. Let's say when you look at the nose, you see the capillaries under the skin. They're really, really fine. Right, they're really, really small. So to answer your question, no, these are specifically the pulmonary veins. These are much larger than the capillaries. And but we speak more to the vessels next week. But we're going to look at that in about 2 more slides. We'll actually see those two things. Good question. All right, so do take note of these names, people, and take note of, follow how the blood flows from the systemic through the heart, through the pulmonary artery, oxygenated, returns pulmonary vein, atria, ventricle, aorta, and out. All right, and this highlights just what we were talking about. It goes to the systemic system and down to the level of the capillaries. Now, it has to get to the level of the capillaries when you're talking about distributing blood to cells and tissues in the body itself. So, that is why you were asking me about systemic capillaries? I don't know.
Yes, sir, that was
right.
why.
Okay, okay. So above this, you could write systemic circulation. So the systemic circulation not only refers to the capillaries, yeah, there's a little bit misleading, right? Ultimately, it reaches the level of the capillaries because the capillaries are the finest. As I say, the arteries, they get smaller, they go into arterioles, and then the arterioles, they move to capillaries. And then you have the exchange of the oxygen with the cells and tissues at the level of the capillaries. Then, of course, it is picked back up. The carbon dioxide is taken back up, and then you have in the from the capillaries it goes to the venules to the vein, and then of course it's returned to the lung, right? So the systemic capillaries, the reason why they put it here, it just represents the point of gaseous exchange between arterioles and venules. But all of this is part, above, as I said, you could write systemic circulation. This is part of the systemic circulation. All right. We look at the heart, we spoke about how the blood flows through, but is it a free fall in the heart? Does the blood just go into your heart and so on? Does it just flow right through? Or are there certain things that restrict the movement of blood in the heart? And the answer is yes, there are, right? And when you look at the heart itself, you have an AV valve, right and left, and you also have a pulmonary and aortic valve. Let me ask you this. Why do you think they call this the atrioventricular valve? Anybody has an idea? It's between what two structures you think?
The atrium and the ventricle.
It doesn't make sense. Thank you very much, Asabi. It doesn't make sense. I, being your teacher, you have all the knowledge you need. The reason why they call it the AV valve or atrioventricular, because it's located between the atrium and the ventricle. If we were to go back, let's have a look. So between the atria and the ventricle, you'd have the atrioventricular valve, right? Atrium, ventricle, atrioventricular valve. And similarly, when we look at the other one, oops, I'm going backwards. This one here, you have the aortic valve, right? And the pulmonary valve, what we'd find them in the aorta and the pulmonary artery. let's have a look at it on the structure itself. Here's the aortic valve, and here the aortic valve is not labeled. No, it's not labeled, right? But this is the aorta here. So you do have the valve going through there, preventing the flow of blood. Not only the forward, well, it doesn't prevent the forward, well, it does restrict the forward flow somewhat, but more importantly, the backflow of blood. Now, why it is you'd want to prevent the backflow of blood particularly? One word, because the heart, you need to build up a certain amount of what? Something beginning with P. Pressure. Yeah. Remember, the blood has to pump out. So it has to get a certain amount of pressure in the heart in order for it to move through the systemic circulation. And those valves are very critical for helping in building up the pressure. And of course, preventing the backflow of blood that you already pump out from going back into the heart itself. So this is just showing the how it is actually made up in terms of here with the atrium, right? Once the blood flows through, you then have the closing off of these leaflets, and it prevents the backflow of blood into the heart itself. Now let's look at the heart. When we look at the heart not only pumps blood, but the heart is made up of tissue itself, in and of itself. So therefore, these tissues must get nutrition, and they must also have a system in which to remove waste. All of these things require blood to flow to the tissue itself. And the blood that flows to the tissue is brought by two means. You have the coronary arteries, and then you have the cardiac veins. Coronary arteries bring the blood to the heart. The cardiac veins take it away from the heart itself. And very interestingly, in terms of the circulation, these are all part of the branch off from the aorta. So just the take-home message from this, circulation to the heart tissue itself is realized via movement of oxygenated blood via the coronary arteries and the removal of deoxygenated blood via the cardiac vein. And this is facilitated in terms of how it actually moves through. It's a branch off of the aorta itself. So the coronary arteries are branch off of the aorta. That is all we need to know at this stage as it relates to the circulation of the heart itself. Now the cardiac cycle. What is a cardiac cycle refers to? Well, the cardiac cycle consists of three parts: a systole, atrial systole when it's at rest, ventricular systole, and complete diastole. Systole is the squeezing, diastole is when it is at rest. So first the atria squeeze, which is the top parts, they squeeze, the ventricles squeeze as the bottom part, and then of course the heart is at rest when it is now filling with blood. So after it's filling with blood, atria squeezes down the blood, squeezes it up through the systemic circulation, then is at rest. So these three parts make up the cardiac cycle. Okay. Looked at the heart, the location of the heart, tissues that make up the heart, the importance of the stimulation of the heart in terms of the stimulation being longer in cardiac muscle than it is with skeletal muscle. We look at how blood flows through the heart. We spoke about the importance of the blood going to the lungs to get oxygenated, and the reason why it goes via the pulmonary artery, even though the blood is relatively deoxygenated after returning from the systemic circulation. So we mentioned why it's called the pulmonary artery, and the reason why, because the blood literally is leaving the heart. And therefore, when in general we look at the heart makeup, like the aorta, when blood leaves the heart, the labeling of the vessels are known as arteries. Veins return blood to the heart. So therefore, the oxygen-rich blood returning from the lungs is known as the pulmonary vein. And then it empties into the left atria, goes down to the ventricle, and then it leaves via the aorta to go into the systemic circulation. So all of these things very important, and it leads up to this point, the conduction system of the heart. So while it is good, all well and good for the blood to be going into the heart, yeah, but it still has to squeeze, and move throughout the body. So the thing is, how does it do it? How does it squeeze? I don't know if you could remember back to your days in school with sports day. Everybody used to have sports day back in school, primary school. No?
Yes.
Remember when you used to dress up with your different, it was house color or what have you not?
Yes, sir.
Yes,
I can still
sir.
remember. I can still remember my house color. My house color was green, but it was Saint Augustine. Yeah, Saint Augustine. I went to San Fernando Boys RC School. Originally, I'm from San Fernando, and I remember Saint Augustine. No. That was in my secondary school. It was Saint Martin de Porres. Sorry. In San Fernando Boys RC. But long story short, when it's sports day, what's the important thing when it comes to marching? What did they have that will make you march? A band, it's giving you some kind of rhythm. Dum 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 dum. And the reason why, what would have happened if you didn't have a band giving you a rhythm? What would happen to the people marching, you think?
Out of time.
Out of time. Right, left, right, left and right, right, all kind of combinations, and you wouldn't look uniform. So therefore, that would be a big problem. Similarly with the heart, remember the heart has all of this tissue, cardiac tissue, and made up of cardiac muscle. And the thing is, the cardiac muscle made up, the muscle contributing to the structure of the tissue. But the thing is, if they didn't get the stimulation at the same time, the heart would literally quiver. And when the heart is quivering, there's a term for that. It begins with F. You say it, oftentimes you see it on TV, right? When somebody, it's a word they use, F, and it rhymes with fibrillation. It begins with F and it rhymes with fibrillation. They say your heart is in
Fibrillation.
Thank you. Fibrillation, yeah. So in order to stop it, what do they use? And it's always, especially on the medical shows, Claire, you see, they rub these two paddles together, doctor or whomsoever medical practitioner is in charge will say, Claire, and then they charge them, and usually you hear the noise go, and they put it on your chest, and boom, and you see the body jump up. So those things that they put on your chest.
No, but don't call it fibrillation. Did I say the patient in VVIB or something like that?
No, the person, it's fibrillation, but what they use to stop the fibrillation is known as a defibrillator. So fibrillation means quivering. So to stop it, D means not. D, usually prefix D means not. So in other words, you're removing the fibrillation. So you use a defibrillator. There are two types. There are the external defibrillators. Those are the ones which most of us will be accustomed to, but you'll also see it professionally when you go into theater and they're doing surgery and for some odd reason the heart stops. What do? They use internal defibrillators, these paddles that they put next to the heart. And they always say clear. Why do they say clear? And everybody, you see people raise their hands. Why do they do that? Anybody?
That the shock doesn't transfer from the person or from the defibrillator to you.
Yes, very good. Thank you very much, Natasha. Yes. So always remember that, some people, you like your lover. Oh God, Frankie, you're going, boy. Frankie, don't leave me. Oh God, Frankie. No, let go Frankie hand, right? Because you literally, if it is Frankie goes, you will be joining him. And that is why, because the shock could be transferred to you. And now you will go into fibrillation as well. Right? So very importantly, you don't want that to happen, and then they'll have to use a defibrillator on you in order to get your heart back into sync. And that's the amazing thing with the heart, in terms of, even though it could go into this quivering mode where the rhythm is gone, when you use a defibrillator, you could actually, what it does is like it restarts the heart. It gets all of these cells in sync again. And they could now be open or receptive to the signal being sent by the SA node. The SA node is known as the pacemaker. So SA node is very much like the drum major or the DJ, as is in most cases it was, having a DJ playing the rhythm. That's the SA node. Doom, 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 doom. How I remember it, SA, whenever I think about SA, I think about South Africa. And when I think about Africa, I think about drums. So that's usually the correlation I make. SA, South Africa, drums. So therefore the SA node, this is the initiator of the pace, right? Starts the pace going. So what happens with the tissue of the heart? You have this electrical conduction system or cardiac conduction system in which the impulses which are generated at the level of the SA node passes throughout the heart and causes the tissues, well, first of all, in the atria, there's a bit of a delay. The atria contract first, and then the ventricles. The atria contract, squeezing the blood down, then the ventricles contract to move the blood respectively to the lungs, and in the case of the left side, throughout the body itself. But the conduction system, very, very important. SA node, then you have the AV node. From the AV node, it goes through this conduction system to the bundle branches, and then down to the smallest part, the Purkinje fibers. SA node, AV node, bundle branches, Purkinje fibers. This is how the electrical impulse passes through the heart itself. And there is a bit of a delay, because if there was not a delay, then the whole heart would contract at the same time, and that'll be useless. You wouldn't be able to move blood from the atria to the ventricles. So there's a delay, a little delay, in terms of the passage of the signal to the lower part of the heart, which allow the atria to constrict or contract first, and then they relax, and then the ventricles follow when they receive this impulse. Have to remember, if we were to throw our minds back to SNF1, that when a muscle receives an electrical impulse, it contracts. I don't know if some people, when they were younger and they were curious, did anybody ever push their fingers into an electrical socket? Anybody ever did that? Or or a frayed
You will
cord?
be alive.
Pardon?
If we did something like that, we wouldn't be alive to tell this story.
No, actually you would. You would. If you push your hand in a socket, you'll feel it, right? You believe you me. You would feel it, but you would be alive. It's not. But if you leave it in there, well, you'll be talking to the ancestors. You're quite right. But usually, when you push your hand in a socket, like a bulb socket, and it switches on, you'll feel it. And not only that, what I wanted to highlight, you'll notice your arm will bend, and that's how it contracts, because of the fact the muscles are receiving an electrical stimulus. And that's what your nervous system does. It produces literally an electrical impulse that goes through your body, and it causes contraction. Anybody who probably has seen persons going through physiotherapy, one of the things they do sometimes, if it is a person who has nerve damage, the physiotherapist will then apply electrodes to the different muscles around the body, and then apply electrical impulses, and you'll see the muscles actually contracting, or because of the fact that they are attached to bone, you would get the movement of the limb itself. I don't know if anybody has ever seen that with a physiotherapist applying electrodes, such that until the person's nervous system repairs itself, right, that the muscles will continue to be exercised. And why is it important for the muscles to get continual exercise? If they don't, they will get smaller, and that condition is known as A. It starts with A. It's 7 letters, and it rhymes with apophy.
Atrophy.
Yes, thank you, atrophy, right? So you don't want the muscle, if the muscles don't get stimulated, they will atrophy, or they will shrink. They literally get smaller. Sometimes, I don't know if you've ever seen somebody who, let's say, was in some type of accident or something, and they've lost the use of, let's say, their arm, from the shoulder down. And you'll notice literally the arm physically gets smaller, it shrinks. And the reason why is because the muscle not getting stimulated. Right? And by extension, we could say, for those of us who go to the gym and, stimulating the muscle all the time, using them, what happens to the muscle? They build up, right? So very important there. Okay, let's go forward. All right. So electrical conduction system through the heart, SA node gives the impulse, starts the rhythm, it goes through,
The atrial.
sorry?
So it goes through the atrial syncytium or something so?
Yeah. So the SA node
Right.
starts the rhythm,
Oh, I didn't
and
have that.
the SA node is located in the atria, the upper, the superior part of the atria.
Yeah.
You're quite right. It passes through the septum. So it's through the septum of the heart. This is where you have the conduction system of the
But
heart actually existing,
drinking much.
right? So the electrical impulse passes through. It goes through from the SA node to the AV node, from the AV node down the bundle branch, and ultimately to the Purkinje fibers, which go through to
The
all
ventricular.
the tissues, yes, in the ventricle, all the tissues of the body itself. One of the important things of having an AV node, this is like a backup though. If something goes wrong with the SA node, the AV node could kick in. It's like having a backup DJ. So imagine you have a DJ on a truck and the generator break down on the truck, right? And no music. So you call the next one, hey, and he turn on his, they turn on the generator there, kick in and right. So the SA node the AV node is really a backup for the SA node. And that is another way, if you'd that the heart has its backup system, just in case something fails, with the primary rhythm generating station, the SA node. You have the AV node as a backup. All right, so that is the rhythm. And how is all of this represented? Well, have you all seen this before? Beep, 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 beep. Looks familiar, right? An electrocardiogram. And what the electrocardiogram is a measure of, it really is measuring the electrical activity of the heart. A little while ago, they recognized that with having, when you measure the electrical activity of the heart by placing electrodes at certain point, if you get variations in the normal pattern, you could then tell if something is wrong with specific parts of the heart as it relates to the electrical activity. So for instance, here you're seeing they devise a system, a PQRST wave, and when you look at particular points, you could actually tell what is wrong with different parts of the heart, which is why you would see it most definitely in your professional career when the doctor comes and is looking at the trace. And now it's on paper, but given time, it would move to a tablet most likely, and he or she will be, just flicking through. But for now, they'll take the trace and they will look through it, move it along on the paper. And you might see them circling certain parts. That's where they see irregularities, because there's a specific height associated with, let's say, going from the QR, this height here is supposed to be of a certain height. This part below the level of the normal wave, this S part from R to S, supposed to have a certain depression. And even the P wave here, it's supposed to be of a certain height. If you notice, it's about about 2 squares high, and the distance from here to here. So all of these measurements, they're very specific for a normal heart. Once you see they are off of or they are larger or smaller than normal, you could tell that something is wrong with the heart. As related to our syllabus, we're just supposed to be aware that the PQRST wave, it tells you the electrical condition of the heart, and you could diagnose certain issues with the heart by just studying the different parts of the PQRST wave. That's all we are to be concerned about. Cardiac output. Take note of this formula is the only one you'll be responsible for in the cardiovascular system. So just take note that it's a product of the heart rate and the stroke volume. All right. Volume, movement of the heart, of the blood. Let's talk about the innervation of the heart itself. Okay, all right. So you're gonna move on to this. I think I'm feeling a little hoarse in my voice. Okay, let's just take a 5-minute water break and we'll continue from here, okay? Coming right back. Okay. All right, good. Yeah, something, I had a little tickle there. All right, so let's get back to the heart. Everybody hearing me?
Yes, sir.
Okay, good. So the innervation of the heart. We mentioned that the electrical activity of the heart itself relates to the fact that the SA node generates the impulse, then goes to the AV node, bundle fibers, and then the bundle fibers, and then to the Purkinje fibers. And that's how it's actually distributed through the heart itself. Now, how is this, the innervation, how is it actually innervated? How is it initiated, sorry? Very interestingly, if you look at the SA node, it is stimulated by the sympathetic input. And two things to remember here in terms of the SA node: the sympathetic input increases the heart rate, whereas the parasympathetic input decreases. So you have two inputs to the SA node. Sympathetic increases, parasympathetic decreases. Is there any way you could think how you'd remember that? Because it's easy to mix it up. Sympathetic input. Well, usually when you have, sympathy for somebody or something, you just feel it, you just have a heavy heart, you feel it a lot. But if you're parasympathetic, well, you don't feel it so much, right? So, yes, while the heart will slow down, but when you're really feeling it, and you get all emotional, so your heart increases. That's how I remember it. Whatever floats your boat is fine. All right, but just to remember that the SA node, the sympathetic input increases the rate, but the parasympathetic decreases it. All right, so that is a very important thing at the level of the SA node. In the ventricular cells, as all the cells of the heart itself, sympathetic input increases contraction strength and stroke volume. All right, so down here, it increases the contraction strength and the stroke volume ultimately. So the stroke volume is increased, the cardiac output is increased as well. So that's how the sympathetic input at both the SA node as well as in the ventricular cells ultimately leads to an increased cardiac output. Okay, looked at the heart, we looked at the electrical stimulation of the heart itself. We look at how sympathetic input increases the output of the heart, and it does so by not only at the level of the SA node, but also at the level of the ventricular cells. Next, we're going to look at the microanatomy then. So we look at the heart stimulation. So how does the blood actually pass from the different structures? So three things to keep in mind as it relates to the microanatomy of blood vessels. You have an artery, you have a vein. The arteries, when they get smaller, they're known as arterioles, and veins, when they get smaller, they're known as venules. And the connecting, or the one common, how they are connected, they're connected across a capillary bed. So for the person who was asking earlier, this is the correlation between capillary beds, arteries, and veins. All right, so the capillary bed, they're very, very small, and they connect both the arterioles and venules together. Interestingly, if you were to see, I want to say there's another cross-section here of what we're looking at here is an arteriole. You would notice that with the arteriole, the tunica media, a tunica or a tunic, anybody here into fashion design or into fashion? What is a tunic? Anybody? A tunic is a what? What type of article of clothing is a tunic? 4 letters and it rhymes with boot. A tunic is a?
Coat.
Thank you, Sparkle. Yeah, it's a coat. So the tunica media, right? This is an arteriole, right? So with the arterioles and with arteries, the tunica media is actually, it's a thick layer, it's smooth muscle cells. And interestingly, when they relax, what you notice with the diameter here. So when the smooth muscle cells of the tunica media, when they relax, this causes the more blood to flow because the diameter of the vessel increases. Now this has a correlation to Viagra. Anybody could see how could want to then, using this knowledge, want to explain how Viagra works? How do you think, what does Viagra do as it relates to the Tunica Media, based on what I just said? Anybody wants to hazard a guess?
So it increases blood flow.
Yes, it increases blood flow, right? So what does it do to the Tunica Media? To increase the blood flow, right? By increasing this diameter, it causes this to relax, very importantly. So that's all that Viagra does, specifically in the area of the penis itself, right? So that's what Viagra does. It increases blood flow such that an erection could be maintained because of that blood flow. And we'll speak more of erections and penile blood flow when we look at reproduction. But an erection is nothing more than increased blood flow to the penis itself. And that is what occurs, and that's what Viagra promotes. It does so by causing nitric oxide, NO. It increases the level of nitric oxide, and the nitric oxide actually causes a relaxation of the blood vessels, causing more blood to rush in. Very interesting. One thing I didn't point out when we're looking at arteries and veins, could you tell me what are the differences between the two? If you're looking at an artery and a vein in cross-section, what are the differences you notice
The
between
vein has
these
a
two?
valve.
The vein has a
Valve.
valve, very good, Alaya, right? So it has a valve. Anything else? Any difference between the two?
artery thicker.
The artery is thicker. So this Tunica Media, which is smooth muscle, it has a larger smooth muscle wall than this one. Is rather thin. So independently, because of the fact that there are smooth muscles located in arteries and by extension arterioles, the arteries themselves, they could contract and move the blood along. Veins, however, that layer is very thin, the Tunica Media. So what do they have to do? They've done an ingenious thing. Usually you'd find veins located in the middle or between muscles. So contraction of the muscles then cause the veins to squeeze. And we'll look at that in just a little while as it relates to the inferior vena cava and the calf muscle, right? That is something very, very, very important at how blood is returned via the inferior vena cava in terms of the location of the vessel as it relates to the gastrocnemius muscle or the calf muscle. We look at that in a little bit. Okay. All right, so capillary beds. Take-home message for us as it relates to capillary beds. The capillary bed is really the connector between the venule and the arterioles, or veins and arteries. That's how you get this interchange. And capillaries, very important with capillaries. Capillaries structurally, they're one cell thick. So this allows for gaseous exchange, which is why at the level of the lung, when we look at respiration in particular, you'd see that you do have, when you have looking at the alveoli, which are covered then by the bronchiole, the smallest parts of the bronchioles, terminal bronchiole, you'll find that there are capillaries which crisscross the alveoli, and that facilitates gaseous exchange because of the fact that the capillaries have spaces between them. They're not rigid, they have some spaces, and that facilitates the gaseous exchange. If it wasn't for that, we'd have a really big problem as it relates to the arterioles and gaseous exchange in the lungs. But we'll speak more about that when we get onto that. That's the next topic after we finish with the cardiovascular system. All right, capillary wall exchange. Don't have to get into the details of it, just suffice it to say that just to appreciate the fact that the capillary walls do allow exchange of gases between them. All right, so the venous return to the heart, you have constriction, skeletal muscle pump, and the respiratory pump. So this is what we're referring to in terms of the inferior vena cava and the location of the inferior vena cava within the gastrocnemius muscle or your calf muscle. So what happens as you move around, you would have constriction and then return of blood. This is very important to take note of, particularly for persons who have poor circulation. If you do have poor circulation causing pooling of blood in the lower extremities, one of the things to remove that very simply is to go for a little walk. So a little, you would learn of that, you know, in your professional career, that, you know, when you do see patients who have, let's say, swollen ankles, and once they don't have a pre-existing, let's say, heart condition or what have you, not simple, just walking around for a little bit, it could actually cause a decrease in the swelling brought on by the pooling of blood and the lower extremities. And the reason why is because of the fact that the inferior vena cava, well, this vessel which leads to the inferior vena cava, it runs between the this muscle here, the gastrocnemius muscle, and in so doing, when the muscle moves, it causes constriction and it moves the blood through to the inferior vena cava. This blood, of course, is under normal blood pressure, 120 over 80, 120 referring to the systolic pressure. And where would you find this 120 over 80? Usually in terms of the blood itself. Well, when it now comes out from the heart, ideally that's where the highest pressure is, and it decreases as it goes through the systemic circulation. So 120 measures the systolic pressure, and the 80 measures the diastolic pressure. So as seen here, you know, when it now comes out, 120 is the systolic pressure, and then it decreases. The diastolic pressure is a little lower. So with this, go ahead.
Excuse me, sorry to disturb you. If someone instead of the 80, someone gets 61.
One of the things is usually viewed not in isolation, but in relation as well to their systolic pressure. So while the diastolic, yeah, so you look at both. You look at both, and then dependent on that, that's one. So that points to something is off. The next thing what should be done is then the person should be given an electrocardiograph. You look at the electrocardiograph to specifically determine where it is that you have the issue, what part of the heart as it relates to electrical activity is giving the issue. So yes, 120, if it is below the 120, it does point to something that is off. EKG will actually pick it up, which part of the heart, and then you could diagnose from there what is needed, what needs to be done in terms of remedying the situation.
So
120, yes, but if it, sorry, let me just finish this one off. But if it's below 120, yeah, that points to bradycardia, it's slow, right? So it could be, the other thing is, did this person have historically, was it always low? Or was it brought about by some change in condition? Was it brought about by medication? So those things have to be taken into consideration as well. So if medication is not part of the equation, well then, yeah, you're looking at the bradycardia. You actually have to look at the EKG, then for a cardiologist to make a call on that one. Go ahead, next question. I hope I don't know if I answered your question. I don't know if I answered your question. I don't know if you want me to go in a different direction. The person who asked about the 103.
So it answered your question, my question, so thanks.
Oh, okay, no problem. All right, and somebody else was asking another question. Go ahead, please.
So
yes.
Not strain, but asking. I've heard doctors tell patients sometimes when, say for instance, your blood pressure could be 90/60 instead of the 128, which is the norm. I've heard them ask if the client is anemic, and they would tell them, well, look, this is another reason if you are anemic, because there is, I don't know, I put it as less blood in your system because your blood pressure again is not the passing of the blood through the arteries, the veins, that kind of thing, so you would get the blood pressure. Are they wrong or are they right?
They would ask them if they're anemic,
yes.
if the blood pressure is high.
No, if it's low.
If it's low.
Yes.
Okay,
they say that's another reason. That's another reason why your blood pressure could be low if you're anemic.
Yes, that's true.
I think that has something to do with, because when you're anemic, you the shape of the red blood cells, it doesn't be completely biconcave, so it doesn't carry as much oxygen, which could cause probably the oxygen level to decrease. I don't know. I assume it.
Right. But if your oxygen level decrease, I'm trying to pick up the logic trail on it in terms of that, because you started off right there, because in terms of, as we looked at last week, you know, the iron is important when you're looking at hemoglobin, right? The heme part actually refers to the iron component of hemoglobin. Globin is the protein, and because of the fact is attached to iron, they call it hemoglobin, right? So the heme refers to the iron. If somebody is anemic, which means they're low in iron, that means the heme component is absent or is very low. So by extension, we mentioned structure and function. If you don't have iron, that means the carrying capacity of the blood is lowered, right? The oxygen carrying capacity of blood. It doesn't have the iron component, the structure is changed, so therefore the function, which is to carry oxygen, that is disrupted. So the amount of oxygen you normally would carry is decreased. How would your body respond to that? Usually it responds to that by secreting erythropoietin, which causes the stem cells to actually make more red blood cells. So therefore your blood volume would go up, right? Literally, you start to produce more red blood cells. It would go up, but not significantly, because we have to remember that it's 5 billion cells, you know, in 1 liter. It's a very large number. But how does that relate now to your blood pressure? Trying to draw a correlation with all of those things, how that would cause your dropping of the blood pressure. Let me get back to you on that one, all right? That's a good question. I don't want to say they're incorrect, because, or am I doubting what you heard? There's probably a very logical reason. I just right now not seeing any correlation, but let me think about it and I'll post it in the chat, in the WhatsApp group, okay?
Okay, sir.
All right, but that's a very good question, Natasha. Thank you. All right. Right, so that's the pressures in the systolic system there, right? You do have receptors in your body that keeps check of the pressure, which I know they are known as baroreceptors. Baro, of course, relating to pressure. Where's the device that is used then to measure the pressure in the air? Is something, if meter means a measure, what do you think is the device that measures pressure? What is it called? A barometer or a barometer, right? So similarly, we have baroreceptors or pressure receptors in the body that actually detects if our pressure is off. And then depending if our pressure is off, we have a response, right? We mentioned that how you have sympathetic system, sympathetic and parasympathetic. The sympathetic system kicks in, that causes an increase, you know, in the heart rate, ultimately leading to an increase in blood flow and increases your pressure. So if your blood pressure does drop, the baroreceptors, it actually signals the brain and then initiates this cascade of things, which leads to an increase in blood pressure. So here is showing here that, let's say if you have some type of trauma, let's say in this case to the leg, a laceration, right? And what does this cause? The baroreceptors present, they increase their rate of activation or firing. The vasomotor center increases the sympathetic activity. We looked just now at the sympathetic activity, right? So the sympathetic activity causes increased sympathetic motor nerve activity. The causes constriction, in this case, of the arterioles. The heart rate and contractility increases to the, well, impulses to the SA node increase, and then you have a constriction of the blood vessels, causing an increase in blood, well, a decrease in blood flow, but at a higher pressure. So increased resistance, this leads to increased blood pressure, right? And the blood begins to flow at an increased pressure. But interestingly enough, let me ask you that, if you, with the increased pressure, wouldn't the blood just keep, wouldn't you get more blood loss happening at this area? And the answer is yes, which is why whenever you do have some type of hemorrhaging occurring, it's always important to stop the hemorrhage either by application of a pressure bandage or some type of bandage to actually stop it, because you could have continued bleeding. Of course, we do have an inbuilt system where clotting occurs, but depending on the nature of the laceration, you know, it could continue. So that's why stopping the bleeding is always very important. All right, so hypertension, we mentioned these. Is this about two slides? Yeah, we almost reached the end. Hypertension, sustained high blood pressure, right? Optimal is 120/80, but hypertension, when you have persistent readings where the systolic is higher, 140. And of course, with the blood pressure measurement, do you all in skills, when you're all doing skills, do you all learn how to do it with the manual sphygmomanometer and using the stethoscope? Or do
Yes,
they teach you all, excellent, right? How do you do it and what you listen to in terms of the blood flow. But of course now, as is often standard in most wards, is the electronic one. You're all familiar with that one as well, yeah?
yes, sir.
Yeah, and how that one is work, I forgot how it work. You just put it around put the cuff around, you don't have to put the cuff, you just, well, yeah, you just place it around the arm and then you just leave it and it will tighten on its own. And then when it gets a reading, it just displays it on the display screen. So that makes life a lot easier. But of course, knowing the principle behind it is very important. All right. There's just a case here. The last thing what I'd want to do is point out is these two diagrams here, the systemic arteries and veins. The major ones, you will be responsible for them. When we look next week, in particular at the circulation, and we look at them in a little more detail, we'll get into a little more specificity related to their function. But do take note of them in terms of the arteries. You should be able to label all of these on this diagram in terms of the arteries and veins. When you look at the naming of the arteries, they're usually named, one depending on their location, or two, well, location related to the structure, or two, depending on the bone that is actually proximal to it. So when you're looking here, your temporal artery, because this here is your temple, and that is a pulse point as well. Facial artery, subclavian, the clavicle comes across here. Brachiocephalic trunk comes here. The palmar artery and the digital arteries. This is the major, the popliteal runs behind the level of the knee, and this is the major artery. Even though you don't want to get this one cut, because if it gushes and you will bleed out. You'll go unconscious in about 4 to 5 minutes if it's not stopped. If you do get a laceration behind the knee, and that is why it actually runs behind the knee for protection. So you'll have the patella and the tibia and the femur actually protecting it. Right, so that is one artery, the femoral. You really don't want to get cut. It will gush. The blood gushes out of there. All right, and then similarly, the arteries and the veins are similarly named. The brachial, cephalic, hepatic, they go to the kidney. Renal goes to the kidneys. Hepatic to the liver. Hemizygous, the gonadal goes to the ovaries or the testes in the male, and ovaries female respectively. Femoral, and again, because of the location of the bone, the femur. Popliteal or knee is the one that runs inferior to the dorsal region of the knee, of the body, behind the knee itself. And this is your tibial artery. All right. So what did we look at today? Well, we looked at the heart. We looked at the location of the heart itself in the mediastinum. We looked at the blood flow through the heart. It goes from atria to ventricles. Then, of course, goes to the lungs by the pulmonary artery, and we mentioned why it's named the pulmonary artery, because of the fact that blood is leaving the heart, and in general arteries are so named because they carry blood away from the heart. Return via the pulmonary vein to the left atria, left ventricle, then it leaves via the aorta. Important to note as well, blood flow going to the heart itself that is carried by the coronary arteries and returned from the heart itself by the cardiac veins. So the coronary artery, cardiac veins, this supplies the blood supply to the heart, and those, of course, are a branch of the aorta. They come off of the aorta itself, and they go down to the heart. The heart, the beating is stimulated by sympathetic impulses, and the sympathetic impulse initiates at the sinoatrial node, the SA node. SA node then goes to the AV node, bundle branch fibers, then to the Purkinje fibers. Bundle branch, then to the Purkinje fibers. Purkinje fibers then throughout the entire heart. So this is how a stimulus initiated at the level of the SA node is carried throughout the heart. Very important. Think about the rhythm that you do have the atria in sync. They all contract at the same time, and then the ventricles. If they don't, the heart will go into a condition known as fibrillation. Very much like if you have jello on a plate and you're shaking the plate, because each one of them is now contracting and relaxing, contracting. They're getting the stimuli by different times. So of course, to stop this, you use a defibrillator. Defibrillator, it resets all of them, and they do then have the, when they now receive it, the impulses from the SA node, they could now contract rhythmically. Each of them could do it now. So you get back this rhythm, and it goes back into the normal heartbeat. So we mentioned also the fact that the blood pressure 120/80 is considered to be normal. Bradycardia, that is the slowing of the heart rate, and tachycardia is when it has the heart rate speeding up. All of these things could be detected when you look at a EKG, which looks at a PQRST wave. And the PQRST wave, in terms of our take-home message, this tells you how efficiently the heart is functioning in different parts of the heart. And it could be detected just by looking at the wave and by prior knowledge, what part of the heart is actually giving trouble, be it the atria, the muscle of the atria, the septum, a hole in the septum. All of these things could be detected just by looking at the PQRST wave. All right. And finally, we mentioned the major arteries and veins of the heart itself. And you were asked, to learn these because they would prove useful in your future knowledge. Okay, that's the end of the lecture. Let me put this stop on the